My name is Deborah Chen. I'm the Vice President of the World Heart Federation and Executive Director of the Heart Foundation of Jamaica. I'd like to start on my right. Sarah.
Hello, everyone. I'm Sarah England. I work for Bloomberg Philanthropies. That's the giving of Michael Bloomberg, the former mayor of New York and now Special Envoy for Climate Change in Cities for the UN. We're working in a number of different areas, including tobacco control, road safety, and several other areas, including obesity control that have a bearing on cardiovascular health.
Good morning, everybody. My name is Manjusha Chatterjee, and I work with the Health Promotion Division of the Public Health Foundation of India, which was founded in 2007 and is a public-private partnership between the Ministry of Health and Family Welfare in India and a number of other international partners.
I'm Trevor Shilton. I'm the National Heart Foundation of Australia's national lead in the area of active living and physical activity. I'm also the Director of Cardiovascular Health in our West Australian office. Our efforts in physical activity nationally are very much centred on walking, cycling, public transport and the built environment, and the way in which the built environment either is a barrier to or an enabler of more people being active. And so I'll be speaking about that today.
And I'm David Watkins. I'm a physician and a researcher. I spend part of my time at the University of Cape Town and also at the University of Washington in Seattle. I'm a research fellow with the Disease Control Priorities Network, which is based in Seattle. And my interest is in the economic impact of chronic diseases. And so I'll be presenting on salt reduction and its broader impacts on the health system.
Thank you very much. Well, cardiovascular disease remains a leading cause of mortality in the world. And at least 80% of the premature deaths can be controlled or prevented by just a few risk factors being addressed, such as tobacco use, salt intake, and raised blood pressure. But our environments at home or where we work can contribute to us developing cardiovascular disease, such as if we don't have safe neighborhoods, it's going to impact on our physical activity. In some of our countries, there may be issues of security and so on. Too few neighborhoods may have poor street lighting. The sidewalks may not be continuous and connected, so there may be problems with approaching traffic. Some schools may not be in areas that are safe, and sometimes the walking distance from home can be a problem. Again, safe areas might be an issue. Our environment can be affected by education in our schools and childcare facilities in terms of physical education. Some countries, it's not compulsory to have physical education as part of the curriculum, and I noticed that when the children get older, it tends to be less and less. And physical inactivity causes 6% of deaths globally, and that amounts to 420 million people. Another problem that we face is unhealthy choices in our environments, such as schools, school lunches, and also in our workplace where a captive audience and what is provided could be more nutritious. Smoke-free space is another concern. Not all of our countries, even those who have signed the Framework Convention on Tobacco Control, not all have yet provided smoke-free environments for their populations. And of course, we know that smoking, secondhand smoking, and smoking do contribute to cardiovascular disease. So with an estimated 70% of people expected to be living in cities by the year 2050, there's many challenges that we need to consider going forward. So in this session, we will hear from our speakers as to how these issues can be addressed and what have been their experiences. So the first speaker I'd like to invite is Sarah, who will discuss the road to heart health, creating healthy choices in your environment. Sarah.
Hello, everyone. I just want to show you a few images to drive home the message that Deborah has just mentioned. If I could get the slides. Click. Here we go. So what is a healthy environment, a heart healthy environment? Basically, it's an environment that's safe and also promotes healthy choices. We just heard that smoke-free environments are one thing that promotes heart health, and clean air in general, including pollution-free air, is very, very important. There are legislative measures, obviously, that can bring these into play. And smoke-free laws are growing in momentum throughout the world now. We're seeing now we've got about 174 parties to the Framework Convention on Tobacco Control. Smoke-free air is a requirement, an obligation to the parties under Article 8 of that convention, and we're seeing a real momentum growing. These are pictures from China, which is one of the places people think of as being particularly smoky, but we're seeing a new draft legislation for national smoke-free law in China. To promote physical activity, it's important to have safe pedestrian zones. Now, a few years ago, this is Times Square in New York, you would have seen Times Square full of cars, full of air pollution, and certainly not somewhere you'd like to walk around. Now, simply by putting some roadblocks and some paint on the ground, we've created a pedestrian zone in Times Square. And ironically, because of the road layout in New York City, it's improved traffic rather than created more traffic congestion. And it's extremely successful for the shopkeepers in the Times Square area. This is now a very valuable piece of real estate for anyone who has a shop front because there's enormous pedestrian traffic. So it's an enormous win for New York City, just creating these pedestrian zones. Contrary to expectations, people thought closing one of the major intersections in Manhattan would have horrendous effects on traffic, but it's proven to be the opposite. So what we can do to promote physical activity and shared public space where people can be more active is, as Deborah mentioned, parks, improving building codes so that people are encouraged to use the stairs, making stairs accessible by keeping the stairs unlocked, and making walking and active transport safer. Safe, effective public transport also promotes physical activity. So this is a picture from Bogota, Colombia, where they have bus rapid transit. So you can see that access to the bus is very safe, even though it's on a busy road. The pedestrians are protected. The buses go faster. They have their own lane. So people can actually commute faster if they're in a bus than they can in a car. Makes it very attractive for people to use public transport. And that, you can see people have to get to the bus shelter by walking to it. And actually from their home to the bus shelter, they do get exercise. So you can imagine that you get more exercise taking the bus or taking a public transport means than you would if you're driving a private car, for example. Another way to create a healthy environment is to tax unhealthy products. This is a picture of cigarette cartons in New York City where one pack costs more than $10. So there's a federal tax, there's a state tax, and there's a city tax on cigarettes in New York City. There's other products that are unhealthy that can be taxed, of course, and there often are, like alcohol. And soda is a new, sugar-sweetened beverages is a new area of taxation that has been pioneered in Mexico. Other ways of discouraging people from choosing to use unhealthy products are ad bans, so promoting legislation to ban all forms of promotion, advertising, sponsorship by the companies that produce these products. So it's stopping them from being glamorized or making them look more desirable than they really are. Here in New York, in this picture from New York City, you can see the cartons and you can see point of sale advertising. So this is what you would see if you walked into a store. You can ban that too. So places like Norway and Canada, you walk into the store, you see a blank cupboard. There's no branding visible. You have to make a request to purchase the object. You can't see it. So that's another way to nudge people away from choosing to use these products. You can also restrict access. You can make it an age limit. I think in many countries, if not all, there's an age limit on access to cigarettes. In New York, we bumped it up to 21 years. So that's a way of reducing access. You can also geographically limit the sales of products, for example, around schools. You can have a geographic barrier that limits sales of harmful products around certain locations like schools, or you can use licensing to do that. You can also use legislative and regulatory measures, policies, to promote access to healthy products. So that's the flip side of this. So you can subsidize things like potassium-enriched foods, or you can promote access to fruits and vegetables. One thing that's been tried in New York City is licensing fruit and vegetable carts to particularly service food deserts or areas where it's very hard to access healthy fruits and vegetables. So yesterday there was a very popular session that got a lot of media attention, and the title was something like "Halt the Salt, Shelve the Sugar, Scrap the Fat." So this is really what this slide is referring to. There are ways to regulate food content. You can regulate the salt content of food. That's been pioneered by South Africa. I think we're going to hopefully be hearing about that a little later, and Argentina. There's some voluntary measures that have also been taken in some countries, and for particular products, there are a large number of countries that have regulated salt content. And the same can happen for sugar and fat. Trans fats, for example, have been banned in several jurisdictions. So regulating food content, labeling, making choices more obvious to consumers are ways that you can make the environment more conducive to heart health. And warnings. I think everybody's familiar with warnings on tobacco packs. If you're here in Australia and you've seen any tobacco packs, you'll see very striking warnings. The same could be used on alcohol, on high sugar beverages, and so forth. So warnings are another part of the environment that can nudge people towards healthy choices. So the bottom line is we're trying to make the healthy choice the easy one, the practical one, and really what people would tend to do naturally. So making a healthy choice the default is what we're after. Thank you very much.
Thank you, Sarah. I omitted to mention earlier to the media that if you could hold your questions to the end, and we'll all be available afterwards to answer any individual questions that you may have. Thanks for your presentation. It was very interesting, and we know the challenges that we face in our countries, and certainly some of the suggestions you have put forward, and New York is a great example we could try and emulate in the various regions. Now we're going to be looking at the topic of shaping national policies to build heart-healthy environments, and we have an example from Australia and South Africa. So I'd now invite Trevor to come and give us his perspective.
Thank you, Debbie. And Sarah, you'll see some striking synergies between your slides and mine, but I guess that's not surprising. I have 4 key messages for you. One which is evident from this first slide is that there is striking and compelling evidence linking physical inactivity with poor health outcomes. Secondly, and importantly, there is strong evidence of the link between the built environment and physical activity opportunities. Thirdly, we have, as you've seen, some examples, wonderful case studies, wonderful exemplars from across the world that we can draw upon. And fourthly, that we now need to move beyond the evidence to translation into policy, translation into case studies, translation into usable tools for our civic leaders to implement these programs. So this slide is fairly self-explanatory. 5.3 million deaths caused by physical inactivity. This comes as a surprise to some, and the next slide was a graph which actually shows that physical inactivity is the 4th leading cause of death in the world, according to data from the World Health Organization in 2009, which also comes as a surprise. These are the measures recommended in the World Health Organization's Global Action Plan for NCDs, and I've highlighted in the red text. This is the section on promoting physical activity for member states, and you'll see writ large in the red text improving urban planning and transport policies and the creation and preservation of built and natural environments that support physical activity. The evidence base for this is very, very powerful as well. So just a few pieces here, some of this from active living research in San Diego and others from the literature. Public transport users, you mentioned the Transmilenio in Bogota. We know that public transport users take 30% more steps than people who drive their car, and that's because of the journey to and from public transport. People who live in neighbourhoods with sidewalks are half as more likely to get enough physical activity to meet guidelines. We know that traffic calming measures and other interventions of that type are effective in reducing pedestrian injuries in this study by 15%. And another Bogota program, the Cicla Ruta, which is a cycle path program, 70% of the participants in that program are meeting physical activity guidelines for health. So in transportation, in this example, we can see that the environment changes that we implement do make a difference. And the same is true in communities, in parks and recreation. Picking off some of these, people who live in walkable neighbourhoods are twice as likely to meet physical activity guidelines. The number of children who are physically active outside is 84% higher when schoolyards are open to them after school hours. You'll see the third one there, that children and youth in neighbourhoods with recreational facilities, 26% more likely to be active than those youth who don't have those facilities. And lastly, if you live near trails, you're 50% more likely to meet physical activity guidelines. So two key messages here is that the evidence around physical inactivity and ill health is compelling, and the second is the built environment does work when it comes to making a difference. So what we're now seeing, and we saw some of this earlier, is terrific case studies, terrific exemplars around the world of civic leaders and local governments and cities who are doing a wonderful job in this regard. Now, you've already seen this one, but this is a pre and post shot of the same image. This is before the intervention, and you can see that 89% of the road space is for vehicles and 11% for people in this iconic New York venue of Times Square. After the intervention, this is what it looked like. And as we already heard from Sarah, this was with little expense. This was with several tins of paint and some outdoor furniture and some movable plants. The interesting thing here is that it was trialled because it was so cheap to do. Let's trial it for a while and see if it makes a difference. And of course it did. And it made a difference not just in getting more people walking on the left here, 6% in Herald Square, 11% in Times Square, but very, very importantly, the shopkeepers loved it. When you get more people there, you get more people buying, and you can see a drop in vacant storefronts and an up increase in retail. So this is a commercially friendly thing to do as well in our cities. Singapore, I'm going to take you to four corners of the world with these four examples. Singapore is probably a world's best case example in relation to public transport infrastructure. And as you've already heard from me, 30% more likely, 30% more steps every day if you take public transport. So this is why this is an important objective for physical activity. In Singapore, 63% of peak period travel is taken by public transport, and the government there plans to increase that to 75% by 2030, so that there will be a train station within 10-minute walk for 80% of homes in Singapore. And it's through a massive investment of $40 billion in that period of time. So Singapore is a world leader in this regard, and Singapore doesn't only have good public transport, it has the other things that are pictured here, which I don't have time to discuss, but good cycle routes, good workplace infrastructure, good community infrastructure, good playgrounds, and they put a concerted effort into their built environment, which I would describe as world's best practice. To the other corner of the world, Sarah, another synergy with Bogota. Bogota, apart from its terrific public transport and other interventions, has this amazing program called Ciclavia. And if you haven't heard of Ciclavia, every Sunday they close 117 kilometre of roads around the city, and there's a walking, cycling, wheelchairing, skateboarding, dancing, and Pilates, and et cetera, celebration. A remarkable event with 1 million people a week. On a rainy day, they only get 700,000. There's nothing like this anywhere else in the world, and its evaluation is compelling. 10% of the population participate in this. Of the people who do, they're 1.7 times more likely to meet physical activity guidelines. and they're twice as likely to cycle for transportation. And importantly, from a cost-benefit perspective, for every dollar invested in this, there's a $3 to $4 return when it comes to health gains. So Ciclovia is just one of a collection of innovative measures in the city of Bogota in Colombia. And it's being replicated throughout the Americas, and you can see here 350 programs across North and South America now called Open Streets, which is the same concept as Ciclovia. So I hope you're getting the message from this, that these built environment initiatives do make a difference. Back to the other corner of the world, and I'll show, this is a smaller scale, but equally important, from Bangkok in Thailand. And this is a new elevated expressway called the Plernchit Expressway. And they built this to reduce traffic congestion. I have a view about that. I think widening roads to solve traffic congestion is like loosening your belt to solve obesity. It doesn't work. We should be investing in walking, cycling and public transport infrastructure, but nevertheless they built this, and in the process of building this they created 623 acres of space underneath it. And you can see in this pre-shot here that 40% of that space is very much unusable, unfriendly, uninviting, and of course all sorts of other social issues that go with that. So what they have done is invested in renewing that environment. An opportunity is created here for health-enhancing land use purposes, and there's just two aftershots there of 5-on-5 soccer and a children's playground. There's community health centres, and Plernchit is the first of 9 of these exemplars in Bangkok which are being constructed. So we have stark choices in our cities. This is an image from Delhi. Urban design, physical activity, and broader health, or urban design for congestion, chaos and ill health. And with the rapid urbanisation we're seeing in our lower middle income countries, this is a vital public health issue. What we now need to do is move beyond the evidence to translation. We need to make these case studies widely available to people throughout the world. We need to package the evidence in easy-to-use formats. And so this introduces a paper I'll be delivering tomorrow on a new resource in Western Australia called Healthy Active by Design. Healthy Active by Design is a succinct summary of the evidence across 9 urban design features, things like the movement network, green space, schools, building design for workplaces, to name a few. And if you go to the website, it takes you to policy links. Very importantly, it provides you with case studies and examples from throughout the world, and equally importantly, it leads you to practical tools. If you're a civic decision maker, a mayor or an urban planner, you can go to a checklist which distills all of the evidence and says, if you want to build effective public open space or an effective movement network, what are the 15 or 16 things that are most likely to make the most difference? So we need to translate now and get this research into the hands of planners, local government decision makers and people who can use it, so we can turn this around. So the lessons learned here, I guess I finish where I started. The evidence regarding physical inactivity and health is compelling. The evidence around built environment changes and the fact that they work is growing and equally compelling. There are wonderful success stories around the world and we need to get better at sharing them. But very importantly, we need to move beyond the evidence to a position where these tools are available for planners and decision makers on how to do it, and we mobilise our best practice globally, and Healthy Active by Design is one example of that. And I'll just finish with the second last dot point there on multi-sector action. I use a term called co-benefit, and I think this is a really important thing. We've mentioned a couple of co-benefits. One of them is increased shop turnover if there are more people walking rather. Very, very importantly, if you get people walking, cycling, taking public transport and being active, you will get the public health benefits that I've been talking about, but you'll also get reduced congestion, you'll get cleaner air, you'll get increased turnover in shops, you will get better sustainability outcomes, you'll get better social capital, reduced crime. So this part of the evidence, a co-benefit thread of evidence, is just as important as the public health benefit. And I think you will all appreciate that if you're talking to a mayor or a decision maker in a city, those things are quite compelling in relation to the arguments. Thank you very much.
Thank you very much, Trevor. Certainly a lot of good ideas and inspiration for us to take from this back to our various countries. I would now like to invite David to give his experience from South Africa.
I realize that my research is actually short on pictures and long on tables and graphs, so rather than bore you with those, I'll tell a story instead. Thanks for inviting me to come and be part of the panel. It's encouraging to me that the abstract that I submitted, which focuses on the health system impacts of salt reduction, was felt to have relevance in a discussion on heart-healthy environments. Because in my mind, the impact of cardiovascular disease on health systems fits into a broader social, economic, and environmental context. And I hope that the ideas and the research that I'm going to share can help us all think a bit more broadly about our strategies as advocates for cardiovascular health. The globalization of unhealthy foods has given us, as global health professionals, a new set of challenges, having witnessed a dramatic decline in under-5 mortality, maternal mortality, and in many infectious diseases. We're now faced with a world in which degenerative and so-called chronic diseases of lifestyle are the lion's share of health problems in most countries. Unfortunately, the donor community and many ministries of health haven't mobilized resources yet to meet this drastic epidemiologic shift. In an era of tightening budgets, decision makers are being forced to reevaluate how priorities are being set across sectors, from health to education to labor and industry, urban planning. After reviewing the evidence, the WHO started to use the phrase best buys to describe the most effective policies to prevent and control chronic disease. And the recommendations included population-based salt reduction programs, the subject of the research that I'll mention in a few minutes. But the term best buys is a bit loaded to me because we don't consume health like we consume bread or smartphones. But we do use our health to participate in society around us. So maybe the concept of a best buy needs to include some of the other things that health policy can accomplish besides health. Which is why the notion of extended cost effectiveness analysis, the approach that we took in the paper, is so interesting to me. It asks the bigger questions like, is our health system causing more problems than it's solving? Are our governments choosing policies and programs that favor the well-off or the least well-off? So you may be wondering why I'm talking about all this economic jargon in a conference on healthy environments. Well, when I think about what characterizes a healthy environment, I quickly begin to ask questions, not just about health, but about economic and social well-being. Is there a high degree of poverty in the community? Are households forced to make difficult choices, like whether to eat or to pay the rent? Is there a high degree of income inequality that fosters violent crime and mental health disorders? Communities characterized by low socioeconomic status are the ones most at risk of unhealthy behaviors around CVD risk factors, like smoking, harmful alcohol use, lack of exercise, which we've already heard is due to a safe built environment, lack of a safe built environment, and of course, unhealthy food options. Part of preventing and building a heart-healthy environment means choosing policies and programs that also address social and economic challenges. Well, there's a wealth of experimental and observational evidence from around the world that confirms that excess salt is bad for the heart, raising blood pressure and leading to premature heart disease, stroke, and kidney disease. And within that body of evidence, there are success stories, countries like Finland and more recently the UK, that have made it a priority to teach the public about salt and hold the food industry accountable for what they're selling. But from the highest levels of government, one might miss the nuances, the impact on households and communities. I want to put the public policy issue in context and talk about how extended cost effectiveness analysis can assist decision makers in developing policies that improve both health and economic well-being in at-risk communities. So let me take you to Langa, which is a low-income urban community in Cape Town. The staple foods for most households include commercially produced breads, processed meats, savory snacks like potato crisps. A loaf of bread costs less than $1. A packet of corn crisps no more than 10 or 15 cents. And when it comes to nutritional choices, I think the 3 A's of health services research actually apply here: availability, affordability, and acceptability. People eat what's around, often regardless of how unhealthy it is. That's the availability issue. They eat what they have the money to buy, even if they know it's not good, because sometimes the choice is eating badly or not eating at all, or eating well and not having the money to pay for your children's schooling. That's the affordability issue. And let's not forget that for many people, salty food tastes a lot better than unsalted food. And so there are acceptability issues around processed foods as well. The fact is, and few people in Langa are thinking of the health effects of their food. They're more focused on the immediate needs, which in a rapidly developing country with high inflation usually revolve around having enough money to buy and do the things they need and want. When we talk about building heart healthy environments, we can't just recommend a bunch of kale and a gym membership for everyone. In reality, we have to start with the decisions that people in low resource settings make every day around their diet, physical activity, smoking, and alcohol use. The South African government began to realize this, and so just as it has been done in the UK, France, and Finland, and other countries, the government convened stakeholders, including Big Food, to develop targets to lower the amount of salt consumed in the population. They set their sights high or low, depending on your perspective, at 5 grams a day. That's at least 3 or 4 grams lower than current levels. And the consensus was that some regulation of salt content in commercially available foods would be necessary. Interestingly enough, the food industry in South Africa asked that the regulations be mandatory, that the playing field be equal, so to speak. Well, the so-called nanny state has gotten some bad press recently. Many people believe that individuals should be left to their own choices and governments shouldn't be interfering with the desire to eat junk food. This political dogma underscores and ignores an essential lesson from economics, which is information asymmetry. Many individuals do not have the appropriate knowledge, resources, or personal incentives to make good choices around their eating habits. And in reality, an epidemic of CVD has huge externalities to the individual, from rising health insurance premiums for everyone to increased greenhouse gas emissions, as we've seen with the physical activity discussion, and as well as the reliance on international supply chains of junk foods. The South African government stepped into this policy space and decided it would be better to nanny a little bit than let the markets dictate the health of the population. And so when we did our analysis of South Africa's policy, we didn't just look at the health gains. Most people would expect a substantial reduction in the burden of CVD. We also looked at how the policy might improve economic well-being for households by saving them the cost burden of CVD. Health systems people call this financial risk protection. And to me, it's a neglected part of the global health research agenda. But in addition to financial risk protection, we looked at the impacts of the policy across the socioeconomic spectrum, from the rich to the poor, to understand who would be getting the most benefits from the policy. What we found was that about 11% of the burden of CVD in South Africa is due to high salt intake. And that goes away when you reduce to appropriate levels. The health effects of the policy were evenly distributed throughout society, which is good news, and I think speaks to the fact that people still have a bias in a lot of circles that chronic diseases are diseases of affluence. In reality, this policy affects the very poor as much as the very rich. And when we added up all the subsidies for cardiovascular disease treatment, basically, they added to about $50 million a year. That's $50 million that the government could be spending on other public health challenges, like building green spaces in communities, supporting community-based health promotion programs. The financial risk protection aspect actually applied most to the middle class, which is surprising. And you might say it's not equitable, but in fact, the government's working very hard already to improve economic well-being amongst the very poor. So I think this is a lesson about South Africa's current efforts, which are very good, to ensure access and affordability of treatment. But this policy goes beyond their current efforts, gives them even a better standing in terms of financial risk protection. So I do think that salt reduction is a best buy, but I think it's a good deal for a lot of reasons that haven't been part of the global dialogue to date. Salt reduction, done effectively, is an additional insurance policy for the lower and middle classes against the potentially catastrophic cost of modern cardiovascular disease treatments. And unlike, say, a workplace wellness initiative that may favor the employed or socially mobile, salt reduction and regulation has an instant 100% coverage across the socioeconomic spectrum, including the urban poor, who are often the ones most reliant on processed foods. So it's a good deal for health equity, too. Ultimately, I think our marketing needs a bit of improvement. In my mind, public policies around dietary risk factors are a social and economic justice issue. The public sector has a critical role to play in providing incentives for food companies to provide healthier, more sustainable foods at an affordable price. The food we eat determines our health, and if our health goes, we're less able to participate in our communities, and we're faced with the soaring cost of health care for preventable diseases. It is my hope that this research will stimulate an ongoing discussion about the role of the public sector and the social and economic benefits of improving our dietary choices. Thank you.
Thanks very much, David. Thank you. And now we'll change tack a bit and we'll hear from Adjusa on the youth focus initiatives to create smoke-free environments. It sounds to me like the food industry is has the same tactics as the tobacco industry.
Thank you, Deborah. When I got an invitation for this press conference, I was wondering why, because it was an abstract on a campaign that we launched in India last year related to tobacco-free generations. But then I realized that, and essentially a youth-led campaign, and I realized that it would be an incredible platform for me to talk about another best buy as far as NCD prevention and control is concerned globally as well as in the national context, and that is the involvement of youth. And we've talked about political commitment, and we've talked about generating an evidence base, and Trevor also mentioned multi-sectoral engagements in dealing with various NCD risk factors. And one thing that sticks out for me, and it's something that I am passionate about and consider myself a youth, at least have the luxury of considering myself a youth for a couple of years, is talk about the involvement of young people in bringing about change. Today, although I work with the Public Health Foundation of India, we also work very closely with another NGO partner, Hriday, back in India. And today I present a small case study from the work that Hriday does. Hriday essentially stands for an acronym which is health-related information dissemination amongst youth, but in the local language, official language Hindi, Hriday also means the heart. And the focus of our work are modifiable CVD risk factors, and Hriday was born out of, was really a response to the epidemiological transition that India was going through with the rise of NCDs. And Hriday has been the mascot in all the work that we do, whether it's the IEC material that's created or the health art that the young people we engage with come up with. And one thing that we've realized through our work over the last 2 decades is that youth must be involved in discussions related to policy change, policy reform, and now in the context of sustainable development, where we are looking to build future generations and make the world livable and healthy for future generations, it is not possible without youth as an important stakeholder in this. And to summarize some of the conclusions that we came to as far as involving youth are concerned is that really the health of individuals depends on individual factors and choices that young people make today, because it determines their future tomorrow. And they are universal motivators for behavior change, whether it is good behavior or bad behavior. And young people basically have the right to health. And youth are an important and powerful change agent. So speaking from the Indian perspective, why should we be working with youth? That's because Trevor mentioned in his presentation about how there's evidence that when there is more access to recreational parks, young people become more physically active. And the same is true for the other NCD risk factors as well. And in India, we have found that now more and more young girls are taking up tobacco use. It's no longer a taboo. There is hardly a differential between male tobacco use among tobacco use among young men and women. And definitely heart disease is on the rise among young people in India. The Hriday concept, very briefly, I'll mention the Hriday concept because, like I mentioned, youth are at the heart of the work Hriday does. And we believe in a model of engaging youth from schools and working there, so teaching them and sensitizing them to the issues and then making them sort of independent enough and empowered enough to take on a leadership role and talk about their health priorities. So we go from the concept of awareness to skill building so that they take ownership of the campaign, and that is what we believe will affect change. Some examples from the work, because tobacco control has also been a forte in what Hriday does and also what the Health Promotion Division at the Public Health Foundation of India does, is here's a few examples from the work that young people have done as far as advancing tobacco control in India is concerned. In 1999, which is when the FCTC negotiations had just about begun, and India did not have a tobacco control law, students from across Delhi, about 25,000 students from Delhi, wrote to the Prime Minister, the then Prime Minister, urging for a comprehensive ban on tobacco advertising. And of course, now we know that India has one of the most comprehensive laws on tobacco control world over, has been a front runner in tobacco control. And I think that we should owe it to the work that the youth did from back then. In 2003, students wrote to the then Health Minister for introducing the Indian Tobacco Control Bill in Parliament. And like I mentioned, in 2003, the act was enforced. Young people have also been enforced in enforcement drives, because we see that there is a law, and this might be true for other countries as well, that you might have a comprehensive law, but implementation is always the problem. It sure is in India. And you need enforcement, and you need good implementation of the law, but you also need someone to monitor that compliance. And what better than have young people do it and then present the results to policymakers so that policies are reformed. Some snapshots of the activities that young people have done, whether it's interacting with policymakers or writing to celebrities. India is a country that worships celebrities, whether it's cricketers or Bollywood stars, and we don't leave a single chance to sort of write to a Bollywood actor when they are found smoking on screen, because I'm not sure if you're aware, but India is one of the first countries to have introduced restrictions on depiction of tobacco use in films and television. And there has been a lot of hue and cry, and the film fraternity has stood up against it, saying that this is sort of detrimental to editorial independence. But I think that it is, the global tobacco control fraternity and the larger global health fraternity has applauded India for the work that is done, and it only remains to be seen whether we are able to implement it properly. And therefore, we have involved young people in a compliance activity again to monitor whether these rules are being implemented in films and television. And here you'll see a clipping from a news clipping where Kareena Kapoor, one of the famous Bollywood actresses, was shown smoking in a popular Hindi film, and we wrote to her saying that, sorry, this is not done. Now I'll come to the campaign, which I, of course, will present in more detail tomorrow during a symposium, but I thought that it would be important to talk about this campaign. The No More Tobacco campaign, the No More Tobacco in the 21st Century campaign, was launched at a conference last year in New Delhi. And it is really, in many ways, a culmination of the experiences of youth engagement over the last 2 decades. But also a beginning, because we want young people to now think about putting an end to tobacco use. The world is talking about the concept of end game. Of course, there is a bit of debate attached to this, because many countries have defined end game in their own way, whether it is minimizing tobacco use to less than 5%, or Singapore has a great example of tobacco-free generation, saying that no tobacco use would be sold to those born in the year 2000 or after. And we in India consider the beginning of the end game to be the ban on smokeless tobacco use, which was brought about in 2012 in our country, because as you may know, that in India, more than cigarette smoking, the use of smokeless tobacco products is far more prevalent. So the No More Tobacco the NMT 21C campaign is really something that we want young people to adopt, and be the leaders for the global tobacco control movement from now on. We've had a lot of people work hard over the last few years, and Deborah, of course, is, because she's been involved in the tobacco control movement for so long, would agree with me where I say that a lot of people have worked hard, but now you need young minds and you need people to innovate and re-energize the tobacco control movement globally as well as nationally. And therefore we thought it was the right time to introduce a campaign like this. So the goals of the campaign really are for young people to assume leadership and to synergize with youth activities and youth initiatives across the world so that everyone comes together collectively to fight for a tobacco-free world, to promote tobacco-free environments, and also to counter the tobacco industry tactics, because we see that the tobacco industry is always 2 steps ahead of us. Their campaigns are always more catchy, flashy, and interesting. And of course, that is because of the money that they pump into it. But if they've got the money, we've got young minds as our assets. And therefore, counter-marketing strategies related to the tobacco industry must be something that young people take up. And all this, we hope, all these activities, we hope will lead to what the global NCD action framework that Trevor also spoke about briefly, is to reduce initiation of tobacco use among youth and adults to less than 30% by the year 2025. I'm just going to end with this slide saying that this is, I thought I'll show you this photo because this is the inaugural ceremony of the conference that we had last year where NMT was launched. And the WHO Director General Margaret Chan was present at the inaugural, and it was the Prime Minister of India also spoke at the event. And but the center stage for the inaugural ceremony was that young student standing right there from the school who spoke about why it is important for young people to be part of the tobacco control movement. And I just want to leave you with this photo because that's the message that young people should take center stage in not just the tobacco control movement, but the larger fight against NCDs.
Thank you, Manjusa. Just before I invite questions, I'd just like to mention that this year, World Heart Day, we have a lot of information about it. The theme will be in keeping with heart-healthy choices and heart-healthy environments. I think we know that too often society blames the individual. You smoke, you eat, you drink too much, you don't exercise. And really, it's the environment that we occupy that really contributes to us making those unhealthy choices. It's so we need to move away from accusing individuals of being unhealthy when in fact where they live and work is contributing to that. So I'd now like to invite questions or comments.
Probably for Trevor or maybe Sarah. I'm quite keen to know how we encourage governments to consider physical activity within a planning model. So I live in Sydney, and it seems to be every time a new development has been announced, the first version of it we see lots of parkland. The second version is less parkland, and by the time it's been built, it's concrete. I guess the question is, how do we encourage more of a how do we encourage those physical activity spaces to be built, and who should be having that discussion? Is it a grassroots movement, or what are your perceptions?
It's a broad question, but I'll tackle it. The part of what you said there was about this is very hard to undo when you've got it wrong. So when we're planning is an important opportunity to get it right. I introduced the notion of co-benefit. I think it's very important to speak the language of the person that you're trying to convince. And so it isn't all about physical activity. Getting more people walking and cycling, and you're introducing the notion of recreational physical activity, has many other benefits as well. It's good for the economy, it's good for disease prevention, it's good for sustainability and clean air. And big issue in Sydney and other Australian cities at the moment is traffic congestion. And yet I'm not hearing much said about walking, cycling and public transport, which is actually the best solution to traffic congestion. So I think part of it is getting the discourse right. I mentioned before the Healthy Active by Design resource in Perth is about mobilising evidence, so packaging that and presenting it in a way that's compelling and convincing. And secondly, that there are case studies around the world, and there are cities in the world who have done wonderful things in what I have to describe as far more challenging environments than Sydney or Perth or Melbourne. So it is doable. It takes political leadership. It doesn't cost a lot of money. In fact, I often get challenged on how much public transport costs, and yet people are not considering how much roads cost. If you invest in public transport, you'll need fewer lanes and fewer bridges and tunnels. So it's often about reinvesting money that we're investing already in a transport network. So a big part of the heart of your question is that advocacy is a big part of this, and we need to mobilise consumers, health professionals and our professional allies around these messages.
Should I just make a comment? I love this question because we're in a world which is rapidly urbanizing. You can see countries like India, China. China's expecting 200 million people to move to cities in the next decade or so. That's almost the population of the U.S. newly moving to cities. So you can, and if you go to China, you see the high-rises going up. They're preparing for this influx of hundreds of millions of people. So this is a golden opportunity to, at very low cost, get it right this time. I'm sure many of you have seen the smog-filled images of Beijing and so forth. I mean, this is a chance for hundreds of millions of people to experience a far healthier environment if we can spread this message and get it right. And it's true in many other countries. In terms of how do you protect parkland, well, I live in Manhattan. It's an extremely congested environment. The property values are very high. So you can imagine the commercial pressure to develop parkland in Manhattan. I work in the same building as Amanda Burden, who is the planning commissioner for New York City. And she created something, well, she's created many things in New York City, including the Brooklyn waterfront, which is parkland now, Battery City Park. But I think she's most famous for the High Line, which is a reclaimed elevated railway. And it was gone to seed, literally. It was an old elevated railway in the meatpacking district that was not used anymore, and it was grass growing on it. And she went up there, I guess they were going to tear it down. She went up there one day and she thought, wow, this is beautiful. And she set about making it her personal mission as planning commissioner to reclaim this High Line as parkland. And it was a big fight because you can imagine everybody wanted their shop kiosk up there on the High Line where, you know, this was a pedestrian thoroughfare. It's more than 2 kilometers long. And she had to continually fight to avoid it turning into a shopping mall, essentially. But the result of that fight is that the property values around the High Line have gone up. It's become a really desirable place to live. And that's really, I don't have an easy answer for you because that's political leadership. That can also grow from community pressure. So if communities value their parkland resources, they can generate political pressure on the leadership to create and sustain these public spaces. But it's not easy, and it requires constant vigilance, I would say, to prevent the encroachment on these park spaces in a congested urban environment. But we have this chance, this enormous chance now to get it right for literally hundreds of millions of people, if not 500 million people, who are very, very soon going to be moving to cities, especially in Asia.
Mm-hmm. Thanks for those comments. Any other questions or comments? Yes.
Yeah, in some context some of our context where we come from, like Kenya or Africa, less in general, is that the tobacco industry always out-argues the government, out-debates the government in the sense that why should you struggle to ban tobacco smoking in public when fumes from vehicles outweighs the amount of smoke that the tobacco churns out. So if in this context you're talking about, I don't know, what kind of plans do you put in place to ensure that maybe, the kind of vehicles people import are those all things that are chance of smoke like nothing else? So, yeah, I don't know what thoughts you have for that.
I can only say that those two things are unconnected. So there is an important legislative and urban renewal agenda about reducing urban air pollution. And it's going to be a big issue in the future. What Sarah has just described to you, I've had described to me as the biggest people movement in human history. People moving to cities in lower middle income countries. And so we need separate legislation, separate approaches to reducing air pollution. It's unrelated to measures around tobacco control. We can entertain the argument about which smoke is most plentiful and which smoke might do you the most harm, but there are compelling reasons for banning smoking in public places and restricting the exposure of people and children to passive smoke. So I would argue that they're both important, but they're not connected.
I think that's an argument the tobacco industry like to throw out there as well. They bring in other situations that need improving, but one doesn't negate the other. They're both important, as Trevor said.
The tobacco industry is finding it increasingly difficult to find anything that is worse than them.
Yeah, they're trying, but... Any other comments? Questions? No. I think that's a final comment. Just to say that what I think is important is intersectoral collaboration. I find that whenever we look at cardiovascular disease, or any disease for that matter, or health issue, we always look at the Ministry of Health. But truthfully, the other ministries need to be at the table. So based on this discussion today, the Ministry of Education needs to be there, physical activity, Ministry of Health, yes, Ministry of Agriculture to do with maybe subsidies on heart healthy foods, urban planners, the Ministry of National Security in terms of countries where there may be, security issues in terms of, where you can live or walk and exercise. So I think that we need to move away from just thinking that cardiovascular disease or non-communicable disease is just a health issue and look at it much more broadly and realize that all sectors have a role to play. And at the end of the day, cardiovascular disease, I think, affects most of us. Most of us have a relative who has high blood pressure or high cholesterol or is overweight. So it's an individual issue as well. So I think we just have to continue working together intersectorally to address this problem. So thank you all for attending, and we'll be available after for any questions.